Hello, my name is Fran, and I am the lead researcher studying normal movement patterns in a group of volunteer subjects. Recently, I noticed that some participants were struggling with basic everyday motions. Two movements in particular stood out: throwing a ball and standing up from a chair. When subjects attempt to throw a ball, they show weak arm acceleration, difficulty lifting the arm fully, and trouble controlling the wrist or maintaining grip. During the chair rising task, the same subjects show slow rising, excessive forward leaning, and knee buckling, as if they cannot generate enough force to stand upright. To figure out why these problems occur, I'll trace each movement through the entire neuromotor pathway from the brain to the final muscle contraction and identify several points where failure can interrupt the movement. Let's begin with the upper extremity movement, throwing a ball. Throwing a ball is a fast, coordinated upper extremity movement. This movement requires coordination between the shoulder, elbow, and wrist. The primary muscles involved include the deltoid, especially the interior fibers, which help lift and flex the arm, the pectoralis major, which horizontally adducts and accelerates the arm forward, the triceps brachii, which extends the elbow during the release phase, and the forearm flexor muscles, which generate grip, strength, and help stabilize the wrist. These muscles are innervated by specific peripheral nerves. The axillary nerve supplies the deltoid. The radial nerve supplies the triceps and wrist extensors. The median nerve supplies most of the wrist and finger flexors needed for gripping the ball. The musculocutaneous nerve helps stabilize elbow flexion during the motion. All of these nerves originate from the brachial plex, which receives contributions from spinal nerve roots C5 through T1. Anatomically, the deltoid attaches from the clavicle and the acromion down to the humerus. The triceps attach from the scapula and humerus down to the old cranium of the ulna, and the pectoralis major anchors the arm to the sternum and clavicle. These attachments create the lever systems that produce throwing mechanics. Next, let's examine the lower extremity movement, standing up from a chair. This is a powerful coordinated action involving the hips, knees, and ankles. The primary muscles involved are the quadriceps, which extend the knee, the gluteus maximus, which extends the hip, the hamstrings, which help stabilize the hip during rising, and the gastrocnemius and soleus, which stabilize the ankle. These muscles are innervated by the femoral nerve for the quadriceps, the inferior gluteal nerve for the gluteus maximus, and the tibial nerve for the calf muscles. These nerves originate from the lumbar and sacral plexus, receiving nerve roots from L2 through S2. In terms of anatomy, the quadriceps attach from the femur and pelvis down to the tibial tuberosity via the patellar tendon. The gluteus maximus connects the ilium and sacrum to the femur. Together, they generate the force to lift the body from a seated position. Now, let's trace the pathway that allow these movements to occur. Both movements begin in the primary motor cortex, located in the precentral gyrus. This region sends the initial command to move. Additional planning comes from the premotor cortex and supplementary motor area, which help coordinate sequencing, timing, and force. Once the command is issued, upper motor neurons travel down through the internal capsule and into the brainstem. A critical step happens in the medulla, where about 90% of the corticospinal tract fibers cross over, forming the lateral corticospinal tract. This is why the right side of the brain controls the left arm and leg, and vice versa. From here, the pathway travels down the spinal cord to the appropriate levels. Throwing relies on C5 through T1, associated with the brachial plexus, and eventually the peripheral nerves serving the arm. Standing up relies on L2 through S2, forming the lumbar and sacral plexus, which supply the hip, thigh, and leg muscles. At each spinal level, the upper motor neuron synapses on a lower motor neuron and the anterior horn. The lower motor neuron carries the signal out through the peripheral nerve and travels all the way to the target muscle. At the neuromuscular junction, or NMJ, the nerve releases acetylcholine, which binds to receptors on the muscle fiber. This starts a depolarization that triggers calcium releases inside the cell. Calcium allows actin and myofilaments to form cross bridges, creating the contract forces that produce the movement. In throwing, coordinated contractions lift the arm, accelerate it forward, extend the elbow, and stabilize the wrist so the ball can be released with appropriate force and accuracy. In standing, the quadriceps contract to extend the knees, The gluteus maximus extends the hips, and the ankle muscle stabilizes the body as it transitions from sitting to standing. If any part of the pathway is disrupted, from the brain to the spinal cord, to the nerve, to the neuromuscular junction, or within the muscle itself, the movement becomes weak, uncoordinated, or impossible. I've narrowed down four possible failures that will cause these problems. The first is the corticospinal tract lesion, the throwing movement. Damage to the motor cortex or descending tract, such as from a stroke or multiple sclerosis, can lead to weak arm elevation, poor fine motor control, and lack of acceleration. The second is radial nerve injury. The radial nerve innervates the triceps and wrist extensors. Injury causes wrist drop, weak elbow extension, and poor grip release, all of which impair throwing mechanics. The third is the femoral nerve injury for the standing movement. The femoral nerve innervates the quadriceps. Damage can cause difficulty in standing the knee, forcing the subject to lean far forward or push off the thighs when standing. And the last is the neuromuscular junction disorder. This is also for the standing movement. This autoimmune condition reduces acetylcholine receptors, leading to rapid fatigue, knee buckling, and failure to generate enough force to rise from a chair, particularly after repeated attempts. In summary, the movements we examine, throwing a ball and standing up from a chair, require coordinated function from the brain, spinal cord, peripheral nerves, neuromuscular junction, and muscle fibers. We identified several points along this pathway where impairments could occur, including a corticospinal tract lesion, radial nerve energy, femoral nerve energy, and neuromuscular junction dysfunction. Understanding where these failures occur helps guide clinical decision making. Diagnostic assessments such as MRI, EMG, nerve conduction studies, and antibody testing for myasthenia gravis can help pinpoint the exact source of dysfunction. Thank you for listening.